The evidence they wanted to, in their case in chief. They're done for now. The defense gets their opportunity to present testimony, evidence, as they choose, in support of their defense, which they presented. And so they have the defense. I'll try to explain to you some of the burden of proof, the state's burden, beyond reasonable doubt. The defense's burden will be something different called preponderance, or greater weight of the evidence. We'll explain how you can working on making certain the first witness is one of those with your video. We'll make sure it's going to work right. So just start to kind of cue that up. That witness will be called, and we reported him earlier. Y'all get to hear that. We didn't quite have the audio worked out then. We do now. That's why that microphone got added. But I've got copies of the testimony, questions, and answers for y'all to look at and read along with if you like. So we'll hand those out momentarily. But it's the defense opportunity to present evidence in support of their defense. We'll continue moving along as they'll call witnesses. Same scenario will go, except they call the witnesses and the state then cross-examine. So it kind of roles reversed. So, with that in mind? I did. I said preponderance. I'll explain the burdens both ways in more detail. Okay? So that'll be my final instruction. You know, the defense has the burden of proving the defense. Most of the all right. Mr. Young.
With the court's permission, I'll hand out a copy of the transcript.
Yes, should be 18 there.
And if everybody will just take one and pass them.
Any objection? Jurors communicated with me. One of them wants to know if they can write on the transcripts. I say absolutely. It's all right. No, good question.
Keep the transcript. I mean, I don't. The state doesn't help to keep the transcript. Normally, they would not be allowed to keep them.
I hadn't thought about that.
That's going to be your discretion, Your Honor. I know typically you don't have to say that, but it's up to you how they take their notes. Or if they want to transfer the like, or however, I will be Your Honor, that's your call.
I'm going to allow the jurors to take notes on the transcript if they'd like, and then they can maintain it with their notes. Your notes are for yourself. You're not pass around and grade each other's notes. Notes are for you. Someone who didn't take any notes, and I'll explain this, is once you're in deliberations and y'all discussing, well, you remember that passage of the case when they were testifying about this? And, well, I remember it this way. I remember my notes after that way. The note taker's notes don't trump the listener's listening. Everybody's got equal footing. It's just how you consider and discuss what was presented to you. So one doesn't trump the other. One doesn't mean more than the other. It's what y'all heard in the presentation of the case. So I will allow the transcripts, if they wish, to be kept with their notes. Take notes on them, but they'll be yours individually, not. Here's what I remember reading my stuff. It's y'all's. It's individually yours. Okay? That's what we'll do.
Okay.
All right?
At this time, the defense called Travis Snyder, and because he was not available to be here when the defense started the case, we videotaped his testimony in this courtroom prior to the beginning of the trial. and we'll play that now. If anybody has a problem hearing, or if I've messed up volume, or if there's too much feedback, please let
Okay.
us know.
Yeah, let me know, and I'll be talking on the microphone. Most of our controls in the back, the media's helping us with this. They're the ones that they've got the cameras here, so they were assisted us in preserving it. So we'll start, and if we need to adjust something, we'll let the guys in the back know, or figure out how to adjust it in here, and we'll go from there. So y'all give me the universal sign for a can't hear, or it's okay. So proceed on. A lot of judges making a lot of racket there, doesn't it?
My name is Travis Snyder, S-N-Y-D-E-R.
Good morning, Dr. Snyder.
Morning.
As you know, we're videotaping your testimony for presentation to the jury at a later time. So we thank you for being here and appreciate the court allowing us this opportunity. Can you tell me what you do?
So I'm a neuroradiologist. So I look at MRIs, CTs, and occasionally X-rays of the brain, the neck, sinuses, and spine.
Can you tell me a little bit about your educational background and training as a neuroradiologist?
So I graduated from Florida State, was my undergrad, and then I went to medical school for 4 years at Toro University in Nevada. And then following medical school, I did a 5-year radiology residency. And during those 5 years, I learned all about radiology in general, including ultrasound, mammography, and emergency room, and of course, neuroradiology as well. And then following the 5 years of residency, I did a year of fellowship. I went to University of Miami in Jackson Hospital. And during that year, I worked under only neuroradiologists. And during each month of that year, I subspecialized within neuroradiology. So I would do 1 month of pediatric neuroradiology, 1 month of sinuses or head and neck. And then I would 1 month of tumors or MRI. So that was that year. And then following that, I graduated from that fellowship in neuroradiology. And then I took a test called CAQ, which stands for Certificate of Added Qualifications. And then I passed that test. Also, I took a separate test, so I'm a board-certified radiologist. And then following that, I've been in practice for the past 4 years now in private practice in Las Vegas.
And have you ever testified before?
Yes.
Have you been found to be an expert in neuroradiology before?
Yes.
Do you know about how many times?
I've probably been in probably 10 trials. I'm just sort of estimating, but approximately.
And the nature of your practice now, can you tell us what it is that what do you do now?
So I work for Simon Med, which is actually I think it's the largest outpatient imaging company in the United States, and so I read MRIs of the brain mostly, or spine, from all over the country, but mostly in Nevada, Florida, Arizona, and California. And so I spend about 90% of my time reading clinical studies for patients. And then I spend about 5% of my time doing research, mostly on traumatic brain injury. We have a large database that we've created where I work with the Department of Defense to try to help understand traumatic brain injury in veterans. And I have other research projects on carbon monoxide poisoning and radiation safety and other papers as well. And then I spend about 5% of my time on expert work such as this, some civil, some criminal. So about 90% is private practice, 10% research, 5% research and 5% expert work.
I'm going to show you what's been marked as defense exhibit number 1. Can you tell us what that is?
Yes, this is my current CV.
Is it accurate?
Yes, this is fairly up to date.
You know, at this time I would move for admission of defense exhibit number 1 into evidence. I don't think that that's appropriate objection. I have always put CVs of my experts into evidence.
I don't know that I've seen it done. I mean, you asked him all the questions of his background training, medical training, practice. Are you going to offer him as a certainly you're going to attempt to offer him as an expert, but why do we need the CV?
Because it goes to his qualifications and expertise. I'm happy to go through his whole CV, Your Honor.
Do that in this
Okay.
CV. I'm not going to admit it. He can testify to it.
Can you tell me where all you have licenses and certifications?
Yes, so I have as I said, I'm a board-certified radiologist since 2015. I have a CAQ in neuroradiology. I have state licenses in Michigan, Florida, Nevada, Arizona, California, Colorado, and New Mexico.
I think we went through most of your professional experience.
Yes.
Do you have any academic appointments?
Yes, I'm on faculty for a number of schools, mostly Toro University, Nevada, and I take 2 or 3 medical students every month. So they come in and they work with me throughout the day, and I try to teach them about radiology and neuroradiology. I'm also an instructor at Michigan State University and in Toro University in California, as well as Nevada, and also at the University of Nevada, Las Vegas School of Medicine. I'm a clinical assistant professor of radiology and an adjunct assistant professor of radiology at the University of Nevada, Reno.
Are you a member of any radiological groups or affiliations?
Yes, the American Board of Radiology, the American Society of Radiology, American Board of Osteopathic Radiology, American Osteopathic College of Radiology, the American Society of Functional Neuroradiology. And actually, I believe I'm on the American Pediatric Neuroradiology. I don't have that listed here, but I'm a part of that as well.
Do you hold any titles or awards?
Well, I was the chief radiology resident in my residency. I'm the Nevada Radiation Safety Officer for Simon Med and the laboratory director for Simon Med in Nevada. There's a few other things I'm not sure that are that relevant for what we're doing here, but.
Have you given a number of presentations and lectures?
Yes, probably over 50 presentations, lectures, articles, and abstracts, many of them on traumatic brain injury. The most recent lecture I gave that's not on here, was about a month ago at Scripps in San Diego. It's a head trauma conference. It's an international head trauma conference, and I was quite honored to give a lecture there on traumatic brain injury.
Have you published any journal articles?
Yes, there's an article on contortionists that's listed here. I have an abstract on IG4-related hypertrophic pachymeningitis. There's another abstract on carbon monoxide poisoning. There's an article on diffuser tensor imaging, which is just recently published, which is not listed here. It's a review of diffusion tensor imaging. And also a article on EEG in traumatic brain injured patients. And then we're working on quite a number of very exciting articles, as I mentioned, with our research group that hopefully will be coming out in the next year or so.
Are those listed under your previous research and current research experience?
Yes, under current research. I'm the principal investigator I'm the lead investigator for the diffuser tensor imaging research for the Department of Defense in the, it's called the BEMA group, or HBOT grant. And also I'm involved with functional fMRI research. And I'm the principal investigator for IRB from Touro University deals with 350 traumatic brain injured cases. And in that research, we're looking at advanced imaging and clinical findings and clinical outcomes based on the imaging. So we're looking at where the injuries are in the brain, what kind of damage that the patients have, and how that manifested as far as their clinical outcomes, so when they got better. Principal investigator for a volumetric software called Neurological and Alzheimer's disease, and also I'm a principal investigator on a carbon monoxide study group where we're creating a database of carbon monoxide patients.
Thank you. At this time, I would again offer Defense Exhibit Number 1, copy of Dr. Snyder's curriculum vitae into evidence.
Testified to everything on there. Testimony is sufficient. The CV does not need to be evidence.
Thank you, Your Honor. Dr. Snyder, at this time, the defense would move to declare Dr. Snyder as an expert in neuroradiology.
Would our solicitor.
It looks like you didn't become involved in radiology until 2014,
Yes. Yes, but I should say in medical school I did also learn about radiology, so that would be since 2005, I guess. Yes. No, it's not, I mean, the CAQ is the equivalent of a board certification, but it's not actually called a board certification. It's a test that you take. The only people eligible to sit for the test are those that have done a one-year neuroradiology fellowship. If you do that year, then you have the option to sit for that test. So it's sort of an equivalent, but it's not technically a board certification. It doesn't exist. Not for neuroradiology, no. Yes, that means just reading cases on patients, yeah. Yes. Well, they're all neuro. I mean, I do some general radiology, so if there's a stat x-ray, I'll look at it, or if there's a CT pelvis or CT abdomen or something that's urgent, I can look at it. But mostly I read the neuro. I predominantly focus on neuro radiology. Mostly neuroradiology.
All right. Dr. Snyder will be qualified in the field of, expert in the field of neuroradiology and can offer opinions in that field.
Dr. Snyder, we're here on the case of Tim Jones. Can you tell me how you became involved in Mr. Jones's case?
Yes, I believe someone from your office, perhaps yourself, contacted either myself or my assistant and asked me to review an MRI. And I believe I was referred to you by Dr. Bigler.
Did we send you an MRI?
Yes.
And how does that come to you?
I'm not sure how this particular one came to me, but a lot of times they're just sent in the mail. A CD with the images are sent in the mail. Sometimes people use Dropbox or some file sharing program to get it to us. So, but in any event, it came to me and I reviewed the images, and then I believe we had a phone conversation and I just discussed my findings with you, and then I said if it would be helpful, I could make a PowerPoint and a report to further explain the imaging findings, and so that's what I did.
It was the mark.
Yes.
What is that?
So this is the report that I did following review of the imaging findings, and this contains summaries of my opinions on the scan, and some literature backing, some literature references, peer-reviewed literature to support my opinions.
Copy of Dr. Snyder's report and evidence.
Mr. Young, I'm assuming that's the same one you sent to
It is.
That's two. Remove the objection.
You need to ask that this is number one.
Okay. They'll be numbered sequentially after the other. That'll be 76, I believe. 78. Also? Okay.
I do not. I think Dr. Snyder might still have it.
Oh, sorry, this one? Oh, I'm sorry.
Dr. Snyder, I'm sure you would like
Yes, this is my presentation, and in this presentation I've saved key images from Mr. Jones's scan and with arrows to annotate them, and there's also some literature references in this. Yes.
That's three without objection.
All right, so Dr. Snyder, you got the CD of Mr. Jones's MRI. Do you know where that MRI was done or when it was done?
It was dated 4/2018, and as far as where it was done, so it says Palmetto, Richland.
Palmetto, Richland?
Yes.
Thank you. So you opened it up, and what did you see?
So yeah, I can go through all the findings. It was first of all, it was a high quality MRI. The first thing I look at as a neuroradiologist to make sure the quality of the exam is appropriate. I think this was a very good quality exam. It was well done with the proper sequences. So MRIs have many different sequences. It's not like an X-ray where you have just one image. There's probably 15 different sequences that were performed on Mr. Jones. And the first finding, and the most striking finding and I can show this on slide 1, is that he has a depressed, there it is. The jury can see that, or there?
Yes.
Oh, okay. There's a large left frontal depressed skull fracture, and the yellow arrows are pointing to that. And the image on the left is a axial image, so that's taken sort of starting at the top of my head going down. These slices are acquired this way, and so that is a kind of through the mid portion of the brain.
So this one's sort of looking down?
Well, it's looking up, actually. It's looking up at the patient, so is this a pointer? I can use this?
Oh, there's a pointer right there.
Oh,
My hand. Here, doctor. That's a pointer. Sitting over there because I've been chasing the cat.
oh, yes. So this is the front and the back, and this is actually the right and the left. So we're looking up at the patient, this is flipped. And this is taken through the mid part of the brain. And this whole area here on the left frontal, this is a depressed skull fracture. So it's pretty large, and you don't have to be a neuroradiologist to see that it's abnormal. And I very rarely see something like this when I review images. So he is a large, and this is from old trauma. There's no question that's the left frontal fracture. And so the image on the right, this is a frontal view. So instead of slicing up to down, we're basically slicing front to back. So it's looking at the patient from the front. So this is the right eye, that's the left eye, you kind of see him there. And then there also is the depressed skull fracture on the left frontal lobe. And here's the normal one on the right. So this is a nice curved linear skull. This one is normal. And then that one is a depressed skull fracture. So that's the first finding. Now, on slide 2, the second finding. So these are, again, axial images. So these are taken up to down, going through the brain. And this is the right side of the brain. And there's that skull fracture we saw before. And this sequence is different than the previous sequence. And this sequence is a special sequence. It's actually quite an expensive sequence to run. I don't know how they did this at their center, but at our centers, this is expensive to run. And it's the best sequence available for hemorrhage. And it's very sensitive for hemorrhage, and the only purpose of this sequence is for hemorrhage. And hemorrhage looks like a decreased signal on this MRI. And so the yellow area is pointing to that black dot, and that's the area of hemorrhage. And there's another one here, and there's a third one here. There's at least 3 areas of hemorrhage. So, and this is not sort of expected because he has a skull fracture, and then he has these hemorrhages which are under the skull fracture, which are well seen on this sequence.
So the fact that the hemorrhages are visible in an old injury, what's the significance of that?
Well, these hemorrhages are consistent with diffuse axonal injury. So that's where there's disruption of the axons, there's disruption of the fiber tracts in the brain. Basically, the telephone wires of the brain are messed up. And hemorrhagic diffuse axonal injury, as we see here in Mr. Jones, is very unusual. Most patients that have head trauma do not have this. It's associated with poor prognosis. For example, there was a study that was done on 100 boxers, and boxers are in the ring, fairly constantly getting hit very hard, knocked out, constantly having head trauma. And in that study of 100 boxers, not a single boxer had any hemorrhage like this. So you have to have a severe trauma, which we know he did because he has a large fracture there. And also, These hemorrhages do over time. About 30% of them resolve. So it's likely that at the time that this trauma occurred, that he had more of these. So he probably had more, and then a few of them likely resolved.
Now, I'm sorry. Let's go on to your third finding.
Well, so that's for the hemorrhages. So he has a skull fracture and underlying scattered hemorrhages in the left frontal lobe.
I know I was going to ask you about the technology to find these hemorrhages. Did that exist 20 years ago, or has it gotten better?
No, it did not. 20 years ago, this sequence called susceptibility weighted sequence did not exist. This is a fairly new sequence, and we do it at our centers, and we're quite proud we have it at our centers. But most places do not even have this sequence. So it's because of it's so expensive. So you have to pay the manufacturers to unlock the key. You have to pay GE or Philips or whoever to get that sequence. So this would not have existed 20 years ago. And this sequence is about 4 to 6 times more sensitive than the next best sequence, which is called gradient echo, or GRE. And there was a study by Tong, 2013, which showed how much better this sequence was than the previous one.
Thank you, Dr. Snyder. Let's go to your third finding.
Okay, so the next slide, slide 3, shows another finding here. And this is showing an area of cortical thinning and scarring. And so the cortex is the outside of the brain. The brain is made up of the gray matter, which is the outside of the brain, and then the white matter, which is on the inside of the brain. And the gray matter, the cortex, is where electrical signals are generated. And then the white matter is where the basically telephone wires. So it's where the signals kind of go through. It's how the brain is connected. And so Mr. Jones has an area, this is right under the skull fracture, and it's right around all those areas of hemorrhage. And in the image in the upper left, you can see it should look like this, where you have the gray matter outside and the white matter on the inside with a smooth transition. Whereas here, it's very irregular, and the cortex is thinned. So this cortex is normal up here. It shows a nice gray cortex, but here the cortex is sort of absent, and it's all kind of blurred. So that's where he has cortical thinning and scarring. And you can see it as well on the image on the left. That this is a coronal image facing us, where you see the arrow pointing to it as well there. And I think it's probably best seen on this middle image, which is another coronal image, which is a sequence called FLAIR, F-L-A-I-R. And it's quite a good sequence to look for that sort of pathology. And the cortex should look like this gray matter coming all the way around, lobulated. This is how the cortex should look normally. Whereas here, it becomes blurred and becomes sort of thinned. And so that is also likely post-traumatic. It can also be seen, this cortex thinning can also be seen in schizophrenia or schizoaffective disorders. But I mean, this is right under where he was hit, so I think post-traumatic etiology would be probably favored.
All right. And were there any other findings?
Yes. So the next slide, we're looking at coronal images of the brain through the mid portion. So this is right about through slicing front to back, right about through the mid portion of the brain at the level almost of the ears. And so this image on the right, this is the right, this is the left, this is up, this is down. These are the ventricles, which are fluid-filled spaces in the middle of the brain. This is normal. And what we're looking at is an area called the hippocampus. And the hippocampus is part of the medial or the middle aspect of the temporal lobe. And the temporal lobe is this area. I'm outlining the whole temporal lobe. So this is the medial part of the temporal lobe. And the hippocampus is this region. And this is the left hippocampus, and this is the right hippocampus. And you can see that the right hippocampus is smaller than the left. And this, and the image on the right also shows it in a different sequence, shows that how the right hippocampus is smaller than the left. And this is secondary. This is an abnormal finding. It's not very common to see this. And hippocampus is an area there's many articles that talk about how it's affected from head trauma. And so certainly that would be consistent with the history of head trauma, especially given all those other findings for head trauma.
Did you put Mr. Jones's MRI showing the hippocampus compared to a normal hippocampus?
Yes, that's the next slide. And this was for the jury to see this is Mr. Jones's brain on the left side of the screen. And this is the same image as before, showing how that right hippocampus is decreased. And you could argue the left is a little decreased too, but it's a little tough to say. But the right we can definitely go with as being decreased. And this is a normal patient. So this is just a normal patient that I see every day reading MRIs. And this is what it should look like. The hippocampus, I'm outlining it with my tracer right here on the right, and that's the left one. And so these are normal hippocampus, and Mr. Jones has that atrophy. And if I could move to the next slide.
Yes, sir.
So that hippocampus connects to other parts of the brain through this tract called the fornix. And the fornix is a fiber tract that extends from the hippocampus. And it's a little tough to see on imaging, but I tried to get some images of it here where the arrow is pointing to it. And you can see how the right one is smaller than the left one. This one is a nice, pretty big left one, and this one is slightly smaller. And it's a subtle finding, but I think it's real. It's seen on 2 slices. This one is smaller than this one. And the fornix atrophy is again is associated with hippocampal atrophy. So if the hippocampus is atrophied, the fornix is also often atrophied because they're connected. And so this I think shows it. And also atrophy means injury. So when the brain is injured, first of all, it swells, just like when you get a bruise on your hand or anywhere. You get swelling, and then following that, it shrinks. But the difference is the brain does not heal like the hand or the foot. It doesn't grow back, so it remains decreased in size because it was injured.
Did you do a slide about the hippocampus and its effects?
Yes, the next slide. And this is just to show how prevalent it is that the hippocampus is injured following brain trauma. There's many articles on it, and these are some of the articles on it. And you see Dr. Bigler, who will be speaking later, actually was very instrumental in discovering some of this. And many other authors as well. And so the hippocampus it's not, my opinion, it's a neuroradiologic fact that the hippocampus is very sensitive to traumatic from trauma.
Are there any other associations with hippocampal atrophy?
Yes, they're a little more unusual, but you can have hippocampal atrophy if you have a seizure disorder. That can cause hippocampal atrophy from seizures. It has been described the temporal horns, which are spaces adjacent to the hippocampus, have been described as larger in patients with schizophrenia or schizoaffective disorder. So that would be also a possibility. Patients with carbon monoxide poisoning are very prone to hippocampal atrophy. There's many articles on that. So yeah, head trauma is not the only cause.
I think you said something about there was a positive correlation between temporal horn enlargement and hippocampal atrophy and schizophrenia. Can you tell us what that means?
So there's a few findings on Mr. Jones that sort of suggest that it's a positive correlation with schizophrenia or schizophrenic spectrum. And those are he has a thinning of the corpus callosum, which is, okay, well, this is the next slide. And this sort of shows it. So let's talk about this. So on the image on the left, this is this is a view we haven't seen before. We've seen the axial view and we've seen the frontal view, and now we're seeing a side view. So this is the front, this is the back, this is up, this is down, and this is right through the center. So this is the midline. So this is right between the eyes and the center of the brain, and this is the corpus callosum, the structure where the arrows are pointing to. And this structure, the corpus callosum, is really the only structure. There's a few smaller ones, but essentially it's the only structure that connects the right brain to the left brain. And it's made up of a bunch of telephone wires, if you will, electrical connectors that the right and left brain communicate. So it's a very important structure, because without it, the two sides of the brain would not communicate. And Mr. Jones see it's kind of thinned here in the front and in the back, and there's a little lump there. And this is more of what a normal one would look like on the right. So in this finding, it's not that well described in traumatic brain injury. You can have injuries to the corpus callosum in traumatic brain injury, but it potentially could relate to a schizophrenia or schizoaffective type disorder. It's a positive correlation. It's very difficult to diagnose schizophrenia or schizoaffective disorder from an MRI. So I want to be clear to the jury that to diagnose schizophrenia or schizoaffective disorder from an MRI is very difficult. But you can suggest that there is a positive correlation. And so it's possible that he may have one of those conditions, but it's not diagnostic on MRI. So the findings on MRI are the temporal horn, which we discussed, the corpus callosal thinning, cortical thinning, and also frontal and temporal lobe atrophy. All can be seen in schizophrenic or schizoaffective type disorders, and he has many of those findings. So it's possible that it's consistent with if he has that, but it requires a clinician to make the diagnosis, not the imaging.
Gotcha. Dr. Snyder, the nature of Tim's brain injury is that, I think we talked about, there were different classifications: mild, medium, severe, or mild, moderate, severe. How does that work?
So traumatic brain injury is classified as mild, moderate, or severe. And it's mostly a clinical diagnosis based on how long consciousness was lost for. Excuse me. But there are some imaging correlates, such as the hemorrhage and the fracture. And so this is certainly not a mild traumatic brain injury. As we mentioned, this is on the more severe spectrum. And so whether this is moderate or severe would require, his clinicians or review of the medical records, how long he lost consciousness, and what his Glasgow Coma Scale was, which is a way to measure neurologic function in someone who has a brain injury. But based on the imaging, this is not a mild brain injury. This is either moderate or perhaps severe, depending on those other factors.
Did you do a slide sort of summarizing your findings?
Yes. So we're almost done. I just have basically two summary slides, and that's. And this slide just sums up all the findings that we've discussed today for the jury to review or have on hand of the imaging findings. And so the first finding is the first thing we saw was the large left frontal anterior depressed skull fracture. We saw left frontal hemorrhagic diffuse axonal injury. Those are all those little areas of decreased signal on SWI, at least 3 or 4 of those. Then he has left frontal focal cortical thinning and scarring, and that might be secondary to, probably secondary to a brain contusion from the trauma. And that cortical thinning and scarring is right next to the hemorrhagic diffuse axonal injury. And then he has right hippocampal atrophy, and he has right fornix atrophy, and that is the medial area of the right temporal lobe, which is atrophic. And so taken all, and the fornix attaches to the hippocampus. And so taken all together, these findings are consistent with a traumatic brain injury, or they're not consistent with, they are. I mean, this is a certainty that they're related to traumatic brain injury, and the degree, it's a fairly advanced traumatic brain injury. And then also we talked about the findings which are not diagnostic of, but there's a positive correlation between the thinning and irregularity of the corpus callosum, prominence of the right temporal horn, and right hippocampal atrophy and left frontal lobe atrophy as well. And these findings have been described in schizophrenia and schizophrenia type disorders, but it requires a clinical correlation.
We've been talking about the damage to these areas of the brain. Can you tell us a little bit about what the significance of those areas are and damage to them?
Yes, so the last slide talks about some of this, and this is what's been described for the frontal lobe injuries. There's been many research articles on, they study patients that have had frontal lobe injuries and what the deficits of those patients are. And first of all, the frontal lobe is the most common area for traumatic brain injury, so that fits with Mr. Jones as well. And some of the symptoms that have been described following frontal lobe injury includes cognitive problems, lower intelligence, lower IQ, and then also problems with executive functions, with personality changes, risk-taking, disinhibition, and behavior spontaneity. So those are all possible deficits that could occur from someone with a frontal lobe injury. And the hippocampal injury that we saw on the right, that is associated with emotional centers as part of the limbic system, and that also has a pretty high function for memory. So memory is involved in the hippocampus. So it would certainly not be surprising if Mr. Jones had some of these symptoms, or I would be surprised if he had no symptoms. I mean, I think that someone that has this degree of a traumatic brain injury would have some sort of symptoms, and these are the ones that we might expect, and this would require his doctors, to examine him or someone to review the medical record to make that determination of which ones of these, if any, that he had. Like,
for instance, low IQ. If he doesn't have low IQ, does that mean he doesn't have poor executive functioning? Are they effects related, or can they be completely separate?
Well, they can be completely separate. And you can have someone that, for example, has severe memory problems, but is very high functioning. Or you can have someone who has severe emotional problems, but is able to do many things that are considered high functioning. And the reverse, there can be someone that is completely cognitively impaired, but they're emotionally stable, personalities are fine, or, so how traumatic brain injury manifests can be very different in different patients, and it's hard to predict based on imaging.
I think he's made it clear that he's not saying if any did or not. In his opinion as an expert, is it possible that somebody has strengths in one area and weaknesses in another?
His expertise in the field of neuroradiology, so he'll limit his opinions to that. So rephrase your question to make certain that's what he does.
Sure. With somebody with this injuries that we've seen here, could they go to college? Is that possible?
Yes.
And get a degree in computer engineering?
Yes, based on the on imaging findings of frontal lobe injury, there's a wide variety of symptoms that have been reported, that can be reported, and the same with the hippocampus, based on the imaging findings. And someone can be, the range that's been reported in the neuroimaging literature is quite broad in terms of what the problems would be. But I think it's very highly probable that someone with this type of injury will have some sort of deficits and have some sort of symptoms, but you can't say what those might be, but these are the likely possibilities.
And I understood, and just want to make clear for the jury, you're not saying that based on this imaging, that Tim's diagnosed as schizophrenic?
No, I'm not.
You're saying that based on these images, he has a brain injury and other brain changes that are consistent or positively correlated with people who have schizophrenia?
Yes.
Is it possible for people to have schizophrenia and get a brain injury?
Yes.
Thank you. One second. Thank you, Dr. Schneider. Please answer any questions the state may have.
Morning, thanks. I believe so. To review them to see if there were any positive findings or any abnormalities. I don't believe so. No. Yes. Yes. I didn't know the time frame, no.
Assuming 4-year lapse between the time you killed the children and the time that you had dating.
Yes.
As far as the findings of the heat now, you got to have your record
No.
from jury and MRI and before that.
Yes, but I don't think there's any question when it occurred because it was such a devastating injury. There should be no debate over when it, I mean, I can't imagine that it's not known when that injury occurred. So,
You not provided any information on the jury record.
no.
We're surprised to know that one of those fractures over 15 years.
No. That would not surprise me.
As far as the findings that go with your discussion about schizophrenia and schizoaffective disorder,
Yes.
you don't know those are all, but those are opportunities that come between you.
No.
And you don't know whether it's changed, whether they put in the time where you get those back out in the 4 years.
I think it would be unlikely that, I mean, the thinning of the corpus callosum, that's, I'm not sure I've seen that sort of develop in a short time period like that. Most of the time, it's something that people have had for, you know, most of their lives, if not all of their lives. Well, I'm not sure if we're born with it, but potentially, or it develops sort of early. I don't know. Yeah, I don't know that I've seen that where you have a scan of someone and then 4 years later there's another scan and then it shows these abnormalities. I mean, most of this is something that is that they've had for a long time. You're right. Yes. Yes, and there's two others. There's cortical thinning, and there's also the left frontal atrophy. And those also have been described in schizophrenic or schizophrenic type disorder. But given that those are in the same location as the trauma, that I think those are likely from the trauma, not from anything else. Yes. Possible, but pretty unusual in TBI to have that, especially when there's if there's hemorrhages in the corpus callosum, then we might, or shearing injuries in the corpus callosum, then maybe it's from that, but it's possible it's from the trauma. Right, and it may not. It may not be from schizophrenia or schizoaffective disorder either, because MRI cannot diagnose reliably schizophrenic or schizoaffective disorder. There's some loose correlations, and a lot of it's in the research phase. So there's findings that are suggestive of it, or there's a positive correlation, but you can't. I'm not saying he has that based on the imaging. Yeah. Not without the clinical correlation. Yes. 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 No, but there are some findings on the MRI that are possibly related to it. There's a positive correlation between the findings on the MRI and schizophrenia or schizophrenic spectrum type disorder. So, I think it's worth mentioning that that if he has that, it's supported by the MRI, but it's not. I can't say that it's more likely than not he has schizophrenia or schizophrenic disorder based on the MRI. There's a few findings that are concordant with that in the right setting. Yes. No. Yes, you're correct. Yes. No, I did not know that. Not very familiar.
Well, wait, he's changed his question, so I'm going to sustain your objection outside the scope, but he may be rephrasing his question. The expert in neuroradiology, so he can answer the question. If it's outside the scope, it is, but I haven't heard the question yet.
Which one? Sorry. Well, maybe you're talking, it was, yes, that was in, that was when before I was in medical school. I worked with a doctor on looking at brain voxels and the effect of medication on that. Yes.
medication can actually cause the effects that you said that you saw?
No, not to my knowledge. There's some research, and the research that we were doing was looking at microscopic voxels, so it was looking at very small voxels, and it was, frankly, it was a little bit discordant, what we were finding and what the literature said. And there are some articles that may talk about how atrophy can occur, but mostly atrophy can occur in the cerebellum, which is in the back of the brain, and that's the most common area that people on antipsychotics such as Haldol specifically, and alcoholism. Alcohol and Haldol can cause cerebellar atrophy, and he doesn't have cerebellar atrophy. So I don't think that the findings that I described are not related to medications. No, not that. No, I've never seen that. These findings. I mean, the findings that related to medication atrophy are in the cerebellum, not in the areas that we discussed. And if there are some articles on it, it's more research based. And what I was involved in, that was like 10 or 15 years ago. So. Yes, 100%. Yes, I don't know what those are, but I would suspect he would have some sort of symptoms given how severe his injury was. No. Correct. Those are symptoms that can occur from traumatic brain injury, yes.
Problems like that, problems judgment, inability to understand abstract concepts, loss of sense of time and space, decreased awareness of self and others, inability to accept more than one or two demands, something, those are that's
Yes.
You can have deficits, paralysis, or weakness,
Those are a little more unusual, the motor deficits from traumatic brain injury, but it's, for example, there's Parkinson's from traumatic brain injury, that's been described, but as far as paralysis, it would be very unusual unless there was a direct injury to the motor cortex, which is in the front and the back of the brain. Yes. Yeah, the frontal lobes are not as, I mean, motor is not a great deficit for the frontal lobes. There may be some involvement, but it's more in the back, in the primary motor cortex. Well, the visual is in the occipital lobes, so that's above the cerebellum in the back, so that would be visual. And then sensory is mostly considered parietal, so that would be more in the back above, so it's in the back higher. That's parietal. That's where sensory is typically. Frontal lobes may have some effect on that, but I don't think as much as the other things we discussed. No. I mean, I think we have a list of all the things that the frontal lobes are associated. They're with personality, they're with risk, inhibition, judgment, memory, and then also there's emotional problems, and which are actually more involving the hippocampus. So, but yeah, cognitive would be one thing that he may have. Yes.
That's the last spot.
Yes.
And then all of them, I think I just finished what I talked about, that you would expect to see from the TBI that you reviewed, correct?
Well, for the frontal lobe, and then hippocampus, we kind of talked about separately.
You just did the motor, which is part of that.
Well, the frontal lobe was the worst, I mean, because he has that skull fracture and he has all those hemorrhages in the front, so that's why I made it for the frontal lobe. I mean, I could have made one for the hippocampus as well, but in my report, I discussed it, but I just didn't make a slide for it.
Frontal lobe is what you saw in the work image. Fair to say?
Yes, I think it is, but not to minimize the hippocampal damage, however.
The frontal lobe injury involved motor function.
Yes,
Numerical,
yes,
executive function and personality, risk-taking, disinhibition, and behavioral spontaneity.
yes, yes, yes.
So those would be some symptoms that you would expect a psychologist to look at based on the findings and see if they use it or not.
Yes, they could evaluate for those, and then, and as we discussed, some are probably more likely than others.
So some are evidence because, right?
Yeah, I'd be very surprised if none of those existed. It's possible, just very unlikely, somewhat very unlikely, in my opinion.
Page 9 of your report, your requirement. So if these are those demonstrated proactive, disinhibition, risk-taking, physical, behavioral spontaneity, and neurological assessment will be consistent with
Yes, yes.
I say that after a traumatic brain injury, that we need to start with the
Yes, if the brain is damaged in a macroscopic sort of way, yes. Yes, yes.
Now, at what point, is it a year, 18 months, that you would expect whatever symptoms that Mr. Griffin is going to have, that it would happen?
I'm not sure. I mean, I can answer generally.
You can generally answer since he knows.
Well, yeah, I mean, a lot of symptoms will manifest immediately, but some take, some will manifest later. There is an inflammatory cascade that occurs following traumatic brain injury if there is injury, and which can occur, which can continue. In fact, there is a risk of patients with. So there was a recent study, 2018, by Barnes, B-A-R-N-E-S, which looked at patients with traumatic brain injury, mild traumatic brain injury, so not like Mr. Jones, but just mild traumatic brain injury where they did not lose consciousness. And that study looked at, it was a large number of veterans over many years, and they found that there was a twofold risk in dementia. So that shows that symptoms can occur decades following a mild traumatic brain injury, even without loss of consciousness. So it's tough to say when symptoms could develop. Some certainly would be expected immediately, and many symptoms actually get better. So a lot of times patients will have most symptoms in the beginning, and then they'll kind of start to generally improve. But some symptoms never get better. Some people are permanently damaged, and then some people, they also develop symptoms later, including sometimes decades later. Well, I was talking about dementia from that study, or such as we talked about Parkinson's related to traumatic brain injury. Often that does not occur right away, so things sometimes take longer to manifest. And so, regarding specific symptoms, I'm not sure. I would rather speak generally because I just don't know. Right. I mean, individual deficits. I don't know when they would show up, but a lot of them probably more immediately, and then some may take longer. And some might be permanent, but I don't know which ones would or not. It's a little out of. Well, I said that those are deficits associated with frontal lobe injury, and the articles describe the studies done, so that's accurate. And then as far as when they occur, yeah, I don't think I don't know that that's really known.
The study that you read described the most of them occurred, there was any occurred.
I mean, I cited a lot of papers. Some of them may have talked about that, but I don't know.
You don't know when that might happen and if I
Well, I think all these, a lot of them probably occur at the time of the injury, but some may not, and some may manifest later, and yeah, I don't know. And any of those symptoms.
So you're saying somebody would have a brain injury 20 years ago, they have memory problems, or associated with DI?
Well, that was what the study from Barnes 2018 found. They found that people that had traumatic brain injury, 20 or 30 years later, they developed dementia from that injury, and they had a twofold risk of dementia.
So you're talking about memory, you're talking about not memory, you're talking about dementia, Parkinson's,
Well, no, I mean, but a dementia is a form of memory loss. So it's under. I mean, there's memory, and then dementia is one form of that. So it's not equivalent. Yes, symptoms do not have to develop immediately from the traumatic brain injury. And in fact, there's many cases, and I've worked with neurologists who specialize in head trauma who see the patients, and they say sometimes the patients, for example, will have a traumatic brain injury, and then they'll go home and they'll rest, or they'll take it easy for a few months, or they'll be kind of incapacitated, and they think they're okay, and then about 6 months later they go back to work, and they start trying to work, and they find they can't work, or they find they can't do things they used to do, and so they don't even realize that they had the deficit. So it's how you measure this can be a little bit, it's not straightforward.
So it would be common for the deficits of when you show up at your house 6 months. So you said that.
Well, I was giving an example, but yes, as far as when symptoms manifest from traumatic brain injury, mostly it would be more immediately, but there can be long-term deficits, like we discussed, which are not uncommon. And other ones too. Well, everything that's on that slide. I mean, someone could have a traumatic brain injury and could have permanent deficits from those injuries. So someone could have permanent memory loss based on a traumatic brain injury. They could have permanent personality disorder. They could have emotional problems that are permanent. So.
My question is,
Correct, might.
but if they won't show up, they will show up shortly after brain injury, 6 months, a year.
I think typically they would, but maybe not in every case.
So you agree with me with sort of dementia or Parkinson, that Mr. Jones is going to have cognitive issues. Is it fair to say that he would have shown up 6 months to a year later? Then that he would develop during that time, and got the best versions to be during that time.
I'm not sure we can say that with a certainty, but it would be, yes, most likely that would occur. But I mean, also, how was it measured? I mean, if he was 15 when he had this, I mean, how was he evaluated appropriately, or was he tested? I mean, those are all questions that are kind of out of my scope. What was it? It was a test, or it was a? And sorry, the question was, oh, sorry. Okay.
But looking at these scores, you would agree with me that at least in the application decision making, he had a 71% already everybody else.
Yes, that's what it says there, and yes, we don't know what he was before. And also, as we said, not all the symptoms from frontal lobe injuries will occur in every patient. So maybe he was doing pretty good in that area, and maybe he was.
I think we're getting beyond scope, so sustained as to a follow-up question on that, all right?
When you were ready to attend the community college for 2 years,
His expertise in neurology, radiology.
without going into detail specifically, you would agree with me, Dr. McHugh, that if I have college transcripts showing what is very good high school transcripts and things like that, that would be very good on this cognition, correct? One of the possible areas that you try that may happen,
Yes, I mean, cognition can be tested different ways, and there can be different manifestations, but if he was doing okay in school, then I guess it did not impact the cognitive, or may not have impacted the cognitive processes involved with those activities.
so regardless of that, he could have done well in school, possibly.
Yes, it's possible.
Could have graduated from college or got a job.
It's possible.
And we're not here today to say because he had a TBI, that's the reason.
No.
That's why the patient,
Yes, it's possible for someone that has brain abnormalities to be relatively normal.
Do you agree with me that all people with abnormal brain scans are unemployed?
I would agree. Well, my billing records, so far I think I've been paid $4,200. $4,270 so far. Yes, and also I should add that I don't take any of that money personally. That money goes to our research. I have a research company, and so I don't get paid from that company either. So the money I do from Expert Witness, activities, they go to fund our research. Yes, yes.
Thank you, Doctor.
Can you redirect?
Did the fact that you got paid in any way affect any of your opinions in this case?
No, not a bit.
Answer that.
I don't think we talked about this, but I know that you and Mr. Graham covered a little bit. If somebody had an initial injury to their brain and then had a subsequent injury in the same area, what does that do?
Well, if someone has a traumatic brain injury and then they have a second traumatic brain injury, then they have a worse outcome than someone without the first traumatic brain injury. So someone that has multiple concussions, they have, each one is sort of, they have a worse outcome if they have multiple traumatic brain injuries. And there's many studies that talk about that. And the theory is that there's functional reserve of the brain is sort of decreased. So there's, if you damage it at first, then you're damaged, and then you have less of an ability to compensate, or the plasticity, neuroplasticity. The brain cannot compensate as much because it's already been damaged from the first traumatic brain injury. So people that have multiple traumatic brain injuries especially tend to have poor outcomes.
Is there any question in your mind about whether or not this is an old injury versus an injury that's somewhere less than 4 years old?
I think it would be very well known when this occurred. I cannot imagine that there's any debate on when this occurred. Other counsel was saying that it was when he was 15. So,
When the skull fracture had refused, is that right?
Sorry?
The skull fracture that was pushed into the frontal lobe had sort of refused, is that right?
Well, it's healed, but it's still depressed. It healed, but it's pushed in kind of on the brain.
Could that have been treated? I mean, if it had been treated at the time, could it have been pulled off the brain to prevent further damage?
I don't think that would have made a difference.
Okay. You were asked a lot of questions about schizophrenia and traumatic brain injury. Schizophrenia is, your understanding that schizophrenia is a brain disease. Is your understanding that schizophrenia can cause changes in the brain?
Believe.
Can schizophrenia cause changes in the brain?
He's not a schizophrenic expert.
I think he offered, if he knows, subject to his expertise, which he testified to earlier, were correlations to such as that, but not treating that. So if it's correlated, he can answer.
Yes, there are neuroimaging research articles and peer-reviewed literature that talks about the neuroimaging findings for schizophrenia, and schizophrenic disorder, as we've discussed. And Mr. Jones has some of those findings on his imaging.
Is Mr. Jones at risk for developing dementia?
Yes, and the study we talked about is a twofold risk in patients with mild traumatic brain injury. And Mr. Jones has at least a moderate traumatic brain injury, if not severe. And so he would be definitely at risk for developing dementia secondary to his traumatic brain injury.
If you heard evidence that he had a significant drop in his grades, began using drugs and alcohol, and other sort of risk-taking behavior, would that stuff be consistent with somebody who has a traumatic brain injury?
It's possible that, given his injuries, that the electrical function of his brain was not working properly. Areas of the brain were overactive or underactive, and therefore he was perhaps trying to treat that with drugs or alcohol. I don't think that is that uncommon, but I mean, I can't say based on imaging that would occur with more likely than not, but it's possible.
Finally, is it possible for somebody who has a traumatic brain, can traumatic brain injury cause schizophrenia?
Can traumatic brain injury cause schizophrenia?
I don't believe there's a very high correlation between that. There may be some theories, but I don't think it's accepted medical fact that traumatic brain injury causes schizophrenia. There may be some research that talks about it, but yeah, schizophrenia does not have a known cause. It's multifactorial, means that it could be some genetic, it could be some environmental, it could be some factors. Potentially, I guess it could be trauma, but I don't think that's an accepted fact.
Yes. All right. We're time for a break. Make sure you put your names on the transcript so you don't get them mixed up. Step back to the jury room, take yourself a nice break. We'll probably have at least 15 minutes, maybe back in here in a little bit. Don't discuss the case.